we have another symposium, which is actually continuation of the session on imaging. And I'm really delighted to share this podium with Valeria Paradies. And we have our expert, Dr. Kevin Croce, connected online. And we go even step beyond the results that we saw previously in the session, OCT versus IVUS, both versus angio. Now we really have a privilege to see demonstration of the new version of the Ultreon 2 and really amazing possibility to further standardize and simplify the use of imaging. And maybe that's the way to go to relieve the operator from some important decision-making process during the PCI and let our artificial intelligence help us make the proper decision. So Kevin, thank you very much for dedicating time and did really wonderful case. And I hand over to you. We start this by showing the case and then we will discuss. There is great audience here from the EBC. You know, people from EBC, we like to discuss, we like to ask questions. So please go ahead.
Yeah, I've long watched some of the wonderful contributions of your organization. And so it's a true honor to be here and be invited to kind of have part of the discussion, share a little bit of our experience with Ultreon 2.0, and I think show a case where some of the power of artificial intelligence, both for case planning and also some of the neat, case assistance menus and the way that we've been using this tool recently. And so again, it's an honor to be here and I look forward to discussion. The case I have has a kind of a neat, lead-in and clinical scenario that I'll go through. Maybe I'll present the details and the baseline angiograms. I'd love to open it up discussion among yourselves, Valeria and Goran and colleagues there, to talk a little bit about what to do. A lot of the fun part about these types of discussions is there's a lot of different ways to approach things. And I know there may even be some geographic differences in terms of how we do bifurcation stenting, US, Europe versus Asia. And so I'm happy to be here, discuss and learn from colleagues. So again, thank you very much for the invitation. I'll bring my slides up now. And they coming through okay, Goran?
Yes, we can clearly see them. Go
awesome.
on.
Great. So, we've started in the US, and I know in Europe also, is to apply an algorithmic approach to image-guided PCI. MLD Max is the algorithm which I think has taken off, at least on our side of the pond. I'm interested to hear about the European experience with this. But I think, to try to increase adoption of image-guided PCI, colleagues, myself included, got together a couple of years ago to try to make image-guided PCI simpler. And this is originally applied to OCT, but at least in our center, MLD Max is the roadmap of how we do IVUS-guided stenting also. And I won't belabor this because I'm sure it's familiar to many in the audience. We can have touch points about it if it's helpful. But you really pretty much boil the case down into two parts. You do a pre-PCI imaging run to assess morphology, length, and diameter, to really outline the map of what you need to do to optimally treat a lesion. And then once the stent is implanted and post-dilated, we look to make sure that the stent is optimized by absence of medial dissections, assess apposition to the extent that it can, affect recrossing and retreating patients, even though it may not drive outcomes as long as the stent is well expanded, and then really focusing on expansion as the main predictor of why stents fail in patients. And so, we looked at MLD Max's behavior in a workflow study called Light Lab. And if you use the OCT information, both pre-PCI and post stent implantation, to assess how the stent has gone in, we see demonstrable changes in physician behavior when they use the imaging compared to what they committed to doing just looking at the angiogram. The type of lesions, decisions about vessel prep, stent diameter, stent length, they're all measurably affected when you use imaging to guide the case. And if you use the imaging to guide your case pre-PCI, there's actually a lot less impact of the imaging on the post-PCI optimization. We think because you get it right when you use the imaging up front. And so this was helpful to me because it really showed, at least in my experience being an operator in the study, that I'll say I'm going to do one thing based on the angiogram, and when I use an imaging catheter, it changes demonstrably what I do in the case in important things like stent diameter, vessel prep, and dealing with underexpansion. And so this has always sort of been a beacon of why I image in cases, and this was taught to me by being part of this study. So without further ado, we're going to talk about a 72-year-old female that I had the pleasure of treating quite some time ago, elective evaluation for CABG versus PCI, which is why she was sent to me and one of my surgical partners. Past medical history is known CAD with an RCA CTO that had been long-standing since 2017, bilateral carotid endarterectomies in 2012, lung disease, type 2 diabetes. She unfortunately was admitted 3 months before I met her with a recurrent gastrointestinal bleed and a type 2 myocardial infarction, which was complicated by congestive heart failure. At that point, she had active bleeding in her proximal jejunum. This was cauterized and clipped, and a diagnostic cath was done, which showed multivessel CAD. Unfortunately, the diagnostic cath at that time was complicated by a right MCA stroke, which was procedure-related. This is actually treated with TPA. She had very good recovery, but they deferred any treatment of her coronary disease with either PCI or CABG, both because the stroke was the main issue and it was a type 2 MI, so they were hoping to defer, let her recover from the stroke, and then reassess. At the time I met her, she was having class 3 angina requiring regular nitroglycerin. I'll share with you the data we had. Her creatinine was 0.69 with a relatively preserved GFR, and a PET stress was done, which showed substantial abnormalities. 39.7% of her myocardium was ischemic with a sum stress score of 27, a sum difference score of 15 with medium-sized, moderate to severe ischemia in the mid to distal LAD, and large area of hibernating myocardium in the distribution of both the PDA and PLV. Her echo had an EF of 50%, which had improved from 40% on medical therapy from a prior hospitalization. And she had moderate aortic stenosis with a mean gradient of 20 with trace mitral regurgitation. These are the diagnostic angiograms which were done 3 months before at the time that she had her embolic CVA around the time of her gastrointestinal bleed. They were unable to engage her right coronary artery well because there's a pinhole sort of functional TO at the ostium. This was known to be present since a long time ago. They tried a bunch of different catheters, but these were the best pictures that we got. This is the left system, which shows intermediate severity LAD and diagonal disease, a well-collateralized RCA. And in the caudal view, you can see probably best here that there's an obtuse marginal chronic total occlusion with left-to-left collaterals. So we submitted her to our heart team. Her syntax score was 37. Clearly, at least from a TVR or target vessel failure standpoint, you'd suggest there's probably a benefit to CABG versus PCI from a revasc standpoint. However, when our surgical team looked at her STS score based on frailty, recent stroke, PVD, et cetera, she had substantial risk of a CABG with an AVR. And so our heart team clinical decision-making was the indication was class 3 angina with a recent non-STEMI. CABG versus PCI, our surgical team felt that because of the recent CVA, stroke, her peripheral arterial disease, her being frail, having had vein stripping and poor conduits and moderate AS, they asked us if we would consider PCI for this patient with the idea that she could get a TAVR in the future when her aortic valve progressed. So our plan was multivessel PCI, for which we have possibly an LAD diagonal bifurcation. The PET was abnormal, but you could consider based on those intermediate severity lesions whether more information is needed. A left circumflex JCTO1, and RCA CTO JCTO4, which had been long-standing since 2017. So with that in mind, I just have sort of 2 stills up of the left system and the LAD, and I'd sort of ask, if we're going to do PCI in this patient, maybe Goran and Valeria, thoughts about revasc percutaneously, and then if you're going to do that, where to start, how to start. There's a lot of open options. There's 3 potential targets: treat the right CTO, treat the circ CTO, or potentially treat the LED diagonal as shown here. So with that in mind, I'll let everybody discuss, and I'm happy to answer any questions, and we can go through what our approach was.
Yeah, perfect. Thank you very much, Kevin. Of course, I start with Valeria. What would your heart team discuss and consider in such kind of patient? But I also invite colleagues here in the room if they want to comment or have different opinion. We have microphones. Please just raise your hand. So what is your consideration for two occlusions, intermediate, true bifurcation LED diagonal, really, 111, but or 011, but with two occlusions and really frail patient? What would you do?
Yeah, it's a complex case. First of all, we have to acknowledge that this is a high bleeding risk patient with a recent bleeding, but also a recent stroke. With a 2 CTO, intermediate lesion in the LED that we want to assess. I think we want to know if that's significant. Yeah, the SPECT probably is not really helping in identify which is the area at risk, and at least in the LED because of 2 CTOs. When we consider the functional assessment of the LED, we have to also take into account that the LED supplies a large territory of 2 CTOs. So that's also a limit. And of course, the moderate aortic stenosis. So probably if the patient hasn't had a recent stroke, that would have been a good candidate for surgery and a concomitant valve treatment. But this is the case. So I think my heart team would have said, okay, proceed with PCI. And I think my next step would have been assessment. And I think it's open for discussion. Functional evaluation of this LED, or you think it's angiographically significant?
Yeah. Anybody wants to comment on this? Dr. Duval, CTO expert. Eve is there. Okay, let's listen to words of wisdom.
So yeah, I agree with that with Valeria that this LED is sustaining also the right and the distal marginal. So I think this lesion, even if it's not very spectacular in LED diagonal, has to be treated. I think this is the first thing to do. It will be quick. It will be quite easy. We'll do a provisional strategy there, treat or not the diagonal branch. And after that, if it's done in, let's say, 20 minutes, then we can go to see better how is the right CTO is probably difficult, but see better how is the CTO the marginal. And to know that, I will come close to the occlusion with a microcat and do a local injection, just to see, not to do hydraulic treatment, just to see how it is tapered or not tapered and so on.
Thank you very much. Yeah, okay, Sudhir.
Yeah, so I kind of agree. And I think the pressure wire assessment of the LED is not going to help here because it's supplying the collaterals to the occluded RCA and circumflex. It will be overestimated. So I think we go to treat the LED in a provisional fashion and then treat the circumflex and decide on the RCA CTO needs to treat on this sitting or next sitting.
Yeah, so, yeah, Dr. Ivelic.
If this is an old lady with a high bleeding risk, can we maybe just treat the LED with the DCB, and that is, we can just do the 1 month on the depth, and maybe because she's living with the CTO RCA for 5 years, as I saw, maybe not to touch now the CTO of the RCA and the marginal to see what will be in 1 month, 3 months or later, and then maybe to decide to do the RCA or marginal branch.
Okay, thanks. Kevin, could you see, or I don't know if you can see us, but I'm sure you can hear the comments and suggestions. So I hand over to you back to see your opinion and actually show us how you proceed.
Great. I can both see you on stage, Goran, and I can hear everybody exceptionally well. So I think all the points raised are wonderful. And, you know, what I was actually expecting was a lot of times in CTO conferences, when we talk about whether to treat the open artery or go after the CTO first, or in courses that I run, I'll ask people to raise their hand. There's a lot more disagreement of which to go after first. And so I'm sort of, you know, solaced by the fact that the experts there agreed to probably start with the LED, which is what I decided to do. And I think the comments about the impact of the accuracy of physiology, given the amount of myocardium subtended by the LED with CTOs, is right on. And so I looked at that as all important parts of this case. And I'll show you what I went through, and maybe we can have a little bit of an idea of a discussion. So our plan was a physiology-guided PCI of the LED, and then fix the left circumflex CTO, possibly in a stage fashion, I think just as was discussed by one of the colleagues there. And then our most recent commentator, I'm sorry I missed your name and couldn't see you. It was one of our female colleagues. I took the same approach, that the right coronary artery had been there for a long time. And although certainly treatable, I would leave that as the last thing to do and just take it step by step. The one potential hazard of treating the LED first is I might make it a little more difficult to go retrograde to get to the right coronary artery, but we can usually get through septals, and I think these are big and they're not angulated. Even if they were stent jailed, I was pretty certain I'd be able to go retro if I had to. There did seem to be a pinhole, at least on the prior pictures, antegrade for the right, but if an antegrade wire escalation strategy to the ostial right coronary artery didn't work, I'd be comfortable trying to go through stent struts in the LED if indeed I decided to stent it. And so great comments, and I'll show you how the case went through as we move forward. And so the first thing we did was we did physiology. This is the data I pulled just to talk about this with my fellows. I was kind of aware of this, but as we were discussing this case, as mentioned by several colleagues there's a lot of myocardium coming off of this LED. So what this study did is it looked at the impact of the change in either IFR or FFR in the LED for indeterminate severity lesions before and after you fix the RCA CTO. And on average, the IFR doesn't move very much. This is on average, 0.86. It goes up to 0.9 when you fix the RCA CTO for intermediate severity LED lesions. So there is some movement. And although on aggregate, most patients don't move very much, there are a couple cases in the scatter plot where the patient goes from 0.5 to 0.8. So I sort of look at this as a scaling issue. You know, if the RFR, IFR is 0.7, in most cases, it's unlikely to normalize. But if it's hanging around 0.86, 0.87, those are the cases where fixing the RCA CTO may actually normalize the LED. And so I'll just bring this up as a point for discussion. Maybe I'll show you the physiology, Goran and Valeria, and ask if there's any interest in discussing this particular point. And if not, we can go on to the image-guided treatment for this patient. Similarly, the FFR moves from about 0.76 to 0.79 on average, with most patients not moving very much, but a couple bumping up substantially. So we did this, you know, I sort of have this in the teaching deck, but the guide was a little bit in and out. So we stabilized with a wire in the circ, did a careful normalization of the wire, and went ahead and did the diagonal RFR pullback. And it was substantially abnormal at 0.73, with the majority of this drop off coming across the ostium, I think, as you might expect. And similarly, this is the LED RFR, with again, the majority of this drop off happening through this region here, where you can see there's intermediate and then moderate severity disease. So I looked at this as being, you know, abnormal enough in both the diagonal and in the LED, where if I had fixed the CTOs, I would not have anticipated that these would normalize to a place where I would see, all right, now the patient doesn't need their LED diagonal treated. One of the things I like about image-guided PCI is, you know, you got to get a second check of the physiology. And a lot of times in my experience, when the physiology looks this bad and the angiogram looks not so bad, I then do either an OCT or IVUS and see that there's a really substantial plaque there. And so any thoughts or comments on kind of rationale for using physiology as outlined here, Valeria or Goran, or would you like me to move on?
Well, I just want to comment that's a really smart indeed use of physiology. In this case, resting index can provide some information, some insights when we cannot probably rely the FFR, considering the large territory supplied by the LED, but the resting index can give some insight about the highest jump. So the pullback is really informative. And I think in this patient with a recent non-STEMI, we can use also the the imaging. So in a complementary role, looking maybe for some features for high vulnerable plaque, because we haven't identified any vulnerable plaque in this patient with a recent no STEMI.
I think there is general agreement, Kevin, in the room regarding the role of physiology, and I suggest to proceed with imaging and discuss the imaging.
Excellent. So, I think standard to our protocol, we're looking to assess the morphology of the lesions, determine the length of stenting, hopefully finding a normal segment, and then assessing the diameter with imaging where we know it has a dramatic impact in terms of choosing stent and balloon sizes. So this is the MLD application of MLD Max. So here is the Ultreon 2.0 OCT pullback of the LAD. It plays a little bit quickly here, but you can see I'll call out in this next panel and then I'll go back. Here's the cursor on the OCT. Here's the lesion at the bifurcation. You can see there's a mild amount of calcium with a relatively small lumen area for an artery that's this big. This is the part that was most physiologically significant on the pullback. And one of the nice things about the new Ultreon 2.0 system, this is using it in the flexible mode. And you'll see here that the AI assists with many things. And so in this particular case, the EEL is visible and is called out by the computer. And I set my margins for landing and choosing stent size based on the proximal bracket here and the distal bracket downstream. For those of you that are used to using AptiView as your OCT software, the newer Ultreon versions have actually flipped such that proximal is on the left and distal is on the right. Those of us that are avid prior software users, it takes you a couple cases to get used to this, having done it the opposite way a bunch of times. So I just have that as an orientation feature. One of the most pleasant new features of this software is on the lumen profile view, the computer calls out graphically the external elastic lamina as this little white line. And so when we go to define the MLD in morphology, length, and diameter of MLD max, it really helps you because outside of seeing the bottleneck of the lesion here, you can start to identify normal segments readily because the place where the lumen and the EEL on this longitudinal view are close together almost always means that there's not much plaque there. And it allows you to say, oh, there's little difference between the EEL and the lumen. That's typically a normal segment. And within the bracketed areas I chose for this case, which is about 28 millimeters long, the computer is smart enough to let me know the luminal dimensions and the EEL dimensions there. It was unable to find the EEL proximal, so you still have to do a manual measurement. And you can see in places where the EEL is not visible, the artery tends to be a little bit more diseased. So I'm just going to go back to the OCT pullback, and I'll try to grab it here and get it to play a little bit more slowly. The other difference you'll notice between the older OCT system and the newer one is the playback typically goes from proximal to distal as opposed to distal to proximal. So a couple of things to get used to as you're starting to use the new software. But you can see the M in MLD max, there's a little bit of swirling, but we don't see major amounts of calcium, and there's a relatively nice normal landing zone here. And so I define a distal segment, which looks good, a proximal segment, which looks relatively good. There's a little bit of intimal thickening. And therein, for me, it tells me I'd be happy to place a 28 or so millimeter stent. And on the computer, we actually have the places where that is. So it helps me to co-register stent placement along the lines of how we're going to do that angiographically. Because I don't have a workstation available to show you, there's actually a feature where you can have this particular still up on the right when you're working, and it will bring in a live angio. So you can be positioning your stent on this part of the OCT screen, looking at where you want to place it with a little call out on the right. And so there's some really nice features of this from a case planning and case execution, which makes things much easier. You can also see
Kevin,
that
if I may just interrupt for a second. What
Please,
I
Goran,
personally liked very much is automatic identification of the side branches, and you have the white dots which really help you with co-registration to know precisely where you are. And I mean, for bifurcation PCI, this is extremely useful feature.
Yeah, exactly. And then it also helps you, if you're going to choose a length of a stent, if you want to go a little bit longer, there might be a hazard of crossing a side branch. And so if we were thinking landing distal to proximal to get more normal, you know right where the branch is. And so a lot of this is really integrated from a case planning standpoint to make things much, much easier. Other comments, Valeria or colleagues?
Well, I just want to underline that basically in one image you have MLD, so you have morphology, length, and diameter, and it seems like straightforward, but in the cath lab when you're performing procedure, having all this information in just one image, it helps in speeding up the procedure, I think.
Just a question for Kevin is that do we plan to cover the first septal branch? Because you have two septal branches going to the right coronary artery. And are you obliged to cover the first one? Are you obliged to cover the first one or not?
So I'll try to, it's hard to get an OCT to run slowly on PowerPoint, as you probably know, but let's look at that question. The septal is right here. And so I'll try to get it to pull back slowly. And I think to Goran's point earlier, in terms of integrating normal, you can land here, I think, reasonably. It's reasonably normal versus maybe pulling back a little bit and getting to more normal. So if you're a CTO person that's saying, hey, I want to preserve that first septal for retrograde access to do the right later, it's certainly reasonable to say you're going to land right here. Can everyone follow that?
Mm-hmm.
As opposed to what I chose to do is to get to a little more normal by going proximal. And this is where I made my measurement. And this is actually the measurement I made for an approximated EEL, because the EEL was not visible because of the extreme amount of atherosclerosis. So this measured to about a 375 by 290-degree views. I'm getting 367 and 4.0. But you bring up a great point, because as much as computers may replace some things in medicine, this still takes a little bit of judgment. You're judging access of the septal for the right later versus getting to a more normal segment proximal. That's a very good point, and I think a nuanced part of how you could plan this case. Excellent.
One more question from Francesco, and then we really need to go through the procedure.
So,
yeah.
According to our experience, where there is no healthy vessel, like here in the proximal part, the safest landing zone is represented by an area where there is no huge plaque burden and a round-shaped lumen, because when you will arrive with the stent, you will be able to perform, let's say, a POT that allows you just to oppose the stent to the vessel wall. If you have oval shape and similar minimal lumen area, you take the risk to have a huge malapposed or risk of dissection.
Yeah, it's a great point. And I think especially in the proximal LED where it tapers a lot, so thinking about pot, balloon tapering length is important. You can look at getting to this segment where the EEL is visible. And you might say that you want to put in a 33 millimeter stent because you like this landing zone better. It's more normal, it's larger, and there's more EEL visible. So these are the kinds of conversations we have in in-case planning. It's normal landing zone versus length of stent. All great points.
Kevin, should we go through the procedure, because we are almost at the end of time? Sorry.
Perfect. Quick OCT look at the diagonal. I'll get through that quickly, just to know that we planned the case there. There's a little bit of chatter initially. I'll skip through to show you the plaque at the ostium of the diagonal. It's quite substantial. So our MLD guided case was the LED lesion was about 25 millimeters long. We measured about 4 proximal, 3.5 distal. The diagonal sizing was 275 based on the OCT, and the lesion was 18 millimeters long. So our MLD wax workflow is a 2.523 in the diagonal posted to 275, and a 3.5/28 in LED posted to 3.5 distal, 4.0 proximal. The nice thing about image guided is you can actually make all these decisions and do a lot of it without taking more pictures. We took a DK crush strategy. I know there may be some difference US versus out of US. I'd be interested in colleagues' thoughts about that. We pre-dilated the diagonal. We pre-dilated the LED. I took a scout angio to make sure I hadn't extended any dissections. We went ahead and put a 2.5/23 in the diagonal as shown here, 7 French radial with a crush balloon present. Put the diagonal stent in, took a scout angio to make sure there was no distal dissections, crushed it with a 3.5 balloon, rewired the diagonal, opened the struts with a Takero, did a 2.5 NC in the D1, a 3.5 NC in the LAD, kissing balloon inflation per standard DK crush protocol, 3.5/28 in the LAD. I did cross the septal to colleagues' point about the fact you could have gone a little bit more distal, but you'll see there is some moderate plaque there. Stent deployed, scout angio there. In this particular case, I wanted my fellow to learn how to use a Sasuke recross. You didn't need to do that because we did pot, but effectively there's a Sasuke dual lumen microcatheter to make sure we're center lumen as we access. I had more than enough room to pot, obviously, in this particular case. Takero to open the struts, 2.75 NC high pressure in the diagonal, 3.5 NC high pressure in the LAD, kissing balloon inflation, 4.0 pot. How did we do? Post PCI of the LED is shown here. There's a small intimal dissection proximally, not clinically actionable. Quite tiny, right there.
Yes.
Yep. Apposition is shown by this apposition indicator. I know it's excellent. You can check it. Our expansion is 98%. Minimal stent area is 98% based on the tapered mode using the OCT. To Valeria's point earlier, the lumen profile in about 4 seconds, you can get a very quick assessment of how you did. No major dissections, excellent apposition, good expansion. We made a similar assessment of the diagonal. The pullback is here in the diagonal. You can see we've got relatively good sizing and no distal dissection. It calculates it at 96% expansion. It's a little tough for the computer to do this because it goes from a big LED into a smaller diagonal branch. Good expansion, good apposition, no dissection. This is the 3D bifurcation view, which is present in Aptiv view. I have a video of it, and you can see the co-registered angiogram. This is really cool. You can actually take this, go back and forth. You get the co-registered angio. You can see how your stent struts look, and you're able to actually interrogate the work that you've done quite nicely. This is the fun feature that we've been using in the past couple cases. So this is the final angiogram. Our Circ CTO I decided to do staged, and question about DAP duration. I think that was brought up earlier, I think by Valeria or one of our colleagues. It's nice to know that you have a well done image guided PCI. So if this patient with GI bleeding doesn't need to be committed to ultra long dual antiplatelet therapy. So one of our colleagues points earlier, this is probably an antegrade wire escalation CTO. We did an OCT guided Circ CTO PCI about a week later, had a nice result, good expansion. And I offered to do the RCA, but both the patient and the referring physician said she felt so well, she never came back for it because that had been longstanding to a colleague's point earlier. And she felt great with the work that we'd done. So thanks for giving me the opportunity to present this. I'd be interested in questions. And I think just for my learning, culotte versus DK crush, I know there may be a difference. Please educate me on your approach because I'm interested in how colleagues that are so expert there would have taken the stenting strategy for this particular patient. Thank you.
Yeah, thank you, Kevin. It's really fantastic case, challenging case. I like to ask Eve, what would be your strategy, culotte, DK crush, or simple provisional? Yes? Provisional and then probably kissing. But we don't focus here on the specific stenting technique. I think it's very impressive, the whole workflow, starting from risk evaluation, discussion of the individual surgical versus PCI risk, and then I think the best decision in the interest of patient, stage procedure, LED diagonal, and then the circ. Anything to add, Valeria?
I think there was an excellent case of how to plan and optimize the procedure. And I think that's also contribute to our discussion about a consideration about depth, because if we optimize the procedure in a high bleeding risk patient, we can probably be safe with the abbreviated DAPT duration.
Thank you very much. Kevin, great case. We wish to have you in Europe for the next EBC meeting with more experience with Ultreon. It's really impressive. I enjoyed very much your demonstration, and I like that 3D bifurcation view is back in the Ultreon 2. So have a good day, and greetings from Warsaw.
Thank you, my friends. Be well, everybody.
Thank you very much all. Well-deserved coffee break.